Welcome to the last presentation of the mini-series on ultrasound of the GI tract. The intent of this presentation is to describe interpretive principles and to provide examples and differentials for alterations from normal that you may encounter during sonography of the GI tract in the dog and the cat. By the end of the presentation, you should be able to identify and describe foreign bodies, identify and describe intussusceptions, and identify and describe mural lesions, which may be diffuse, multifocal, and/or focal. In addition, I want you to be able to have some appropriate differentials for those mural lesions. We can apply similar interpretive principles as you have learned in radiography and the upper GI series using the Röntgen or radiographic signs. With ultrasound, remember that we can look at motility, but then we'll use all the others of location, number, size, shape, echogenicity in place of our opacity. And then I specifically want you to really look for the presence and absence of the intestinal wall layers, and you can also look at margination. As you've already learned, lesions can be classified into intraluminal, mucosal, mural, or extramural, and we'll maybe talk about that as we go through examples. When we look at ultrasound of our GI tract, I think it can help us to think of pathology as abnormal function, abnormal content, or abnormal structure. Now, under abnormal structure, I've listed stricture as a possible abnormal structure, but we're not going to talk about that because strictures are very challenging to identify with ultrasound. Let's start with abnormal function. Just as you've learned with radiography of the GI tract, we can think about ileus and we can classify it into mechanical or obstructive and functional or non-obstructive. We can look for that segmental distension of portions of the intestinal tract when we are thinking about mechanical obstruction. So the patient on the right side of the slide here has a very distended segment of jejunum, and it is adjacent to a completely non-distended segment of jejunum. And so this would be kind of our classic two populations, segmental distension and non-distension, that we might see with mechanical or obstructive ileus. When we actually look at motility in these patients acutely, they oftentimes have increased peristalsis. I don't have an example here of functional or non-obstructive ileus, but we would look for generalized, maybe mild distension and actually have decreased or lack of motility. So that would be a uniform population of less distended intestine. You'll notice throughout the presentation that I will have slides that have additional labeling and shading on them, and we're not going to talk about those, but they are for your learning and study later. Another thing we might identify when we're talking about function is spasticity. And spasticity in an intestinal segment is oftentimes secondary to regional disorders like pancreatitis or peritonitis, but can be seen with some inflammatory disorders such as irritation or inflammatory bowel disease. The segment of jejunum on this slide is showing us some of this spasticity or corrugation when we look at this wall and how kind of spastic looking it is, corrugated like cardboard, compared to our normal jejunal segment with just kind of uniform wall there on the bottom right. Let's move into talking about abnormal content. And one of the most common, encountered abnormal content is when we identify a foreign body. Foreign bodies are more easily identified in the small intestine. They can be quite challenging in the stomach, and that's because the stomach is oftentimes very gassy, and that gas will cause shadowing and reverberation, which precludes looking at the lumen. When we identify a foreign body, most often they are very well-defined, hyperechoic kind of interfaces within the lumen of the intestine. And most foreign bodies will have associated acoustic shadowing. So a very bright interface and then pretty much immediate and usually very clear acoustic shadowing, so very discrete shadowing. A few types of foreign bodies like superballs or shelled nuts may not shadow, so they may have an atypical appearance. If the foreign body is obstructive, we can look for signs of mechanical ileus, so we would see proximal or orad distension of the lumen of the intestine. And again, oftentimes acutely, you will actually find hypermotility or hyperperistalsis. As a foreign body has been sitting there more chronically, then they might actually start to have ileus or lack of peristalsis. Typically, the intestinal wall will be fairly normal, but if the foreign body has been sitting there for some time, we might have some thickening of the wall, and sometimes the wall appearance will be altered due to edema or inflammation. So here's an example of a foreign body within the jejunum of our patient. This is a longitudinal image of the jejunum. I can see the wall that has fairly normal layering superficially here. And then here's our deep wall. And here is some luminal anechoic fluid that is somewhat distending the lumen. And it leads up to this more medium echogenicity interface that has discrete associated shadowing. In transverse, we can again see this kind of hyperechoic interface. It looks a little bit more irregular and then has discrete shadowing. And then the wall is a little bit more challenging to see here because of our resolution. This foreign object was obstructive and turned out to be a pine cone. Here's another example of a foreign object within a segment of jejunum. The foreign body itself is this hyperechoic discrete line with very discrete acoustic shadowing within the lumen of this jejunal segment. Proximal to it, there is some change in the wall where the mucosa is a little bit thicker and hyperechoic. Here's a little bit more normal wall on the other side, and there is some fluid distension. And if we look on the images to the left of the slide, we can actually see that this patient has a very distended stomach filled with anechoic fluid and a very distended duodenum filled with anechoic fluid. They are so distended that the walls are very thin and we can't see the layering because of that. However, if we look at this foreign body and distal to it, again our foreign body with discrete acoustic shadowing, notice this jejunal segment now is completely collapsed. So we have a little bit of a linear echogenic line for the lumen wall on either side, so no distension. So this one is completely obstructive. Here's an example of another jejunal foreign object. So if I look over here on the bottom of our slide, our foreign object is the discrete hyperechoic area with discrete acoustic shadowing. This is longitudinal. This is transverse. Proximal to that, the jejunum has some echogenic luminal fluid distending it. Here is another portion of jejunum that's distended by gas, so we have more dirty shadowing. So compare that dirty shadowing to the very discrete acoustic shadowing. Another proximal segment of jejunum contains some echogenic fluid and gas. Similar in the duodenum, we have some echogenic fluid and gas. And then here's the stomach that is distended and at least has some gas in it, which is causing a lot of reverberation and dirty shadowing. And this shows us why we can't easily identify a foreign object in some of our patients' stomachs. Here's an example of one of the atypical foreign bodies. This is a cat that actually has an almond foreign body. This is a segment of the proximal duodenum. And the foreign object itself looks different. It's kind of this hypoechoic structure that is within the lumen. Notice there really is no shadowing associated with it, maybe just a little bit of edge shadowing off that round part. Here is the wall on the deep side and the wall on the superficial side. So this is a foreign body that doesn't shadow and isn't hyperechoic. And then proximally, the stomach is quite distended as well as the very proximal duodenum. This is the level of the pylorus. A special case of foreign body you've seen on radiographs and probably the upper GI series is the linear foreign body. Most linear foreign bodies, if we identify them on ultrasound, can cause a classic ribbon candy-like plication. And if I look at this image on the left of the slide, this is that kind of ribbon candy plication. So the blue arrows are depicting the outer margins of the intestine, and this is a little bit challenging to see, but if you look where my mouse is, I am showing you this plicated appearance. So all of these kind of loops here are the intestinal walls kind of gathering together. The patient on the right has a linear foreign body here that is anchored between a hyperechoic shadowing foreign body in the proximal portion of the segment, and then a hyperechoic shadowing foreign body in the distal portion of the segment. So two luminal foreign bodies, and then there is plication here from some sort of a linear structure that is connecting those two. Another form of abnormal content is the intussusception. And the intussusception has a multi-layered appearance of concentric rings, sometimes called a ring sign. And this is when your intussusceptum, which is the more proximal bowel that telescopes into the more distal bowel, called the intussuscipiens, is seen in usually transverse. And so this is a transverse image of an intussusceptum. And it looks like there are multiple rings here. Here is our inner intestinal portion, and then here is our outer intestinal portion. So again, more layers or more rings that we would see in a normal wall layering. Oftentimes some other content goes in, maybe a little bit of mesenteric fat. This fat is a little bit kind of hyperechoic to the other portions of the wall. Here's another example of an intussusception. I have a longitudinal image and a transverse image. On longitudinal, you can see the more proximal portion of bowel here that is telescoping in to the more distal receiving portion of bowel, and then there's a little bit of hyperechoic fat in there as well. Now this patient has some altered echogenicity to the wall. Mucosa is a little bit more hyperechoic. It's a little bit challenging to see the layering, and that is probably because of a combination of edema and inflammation that can happen if you have any ischemia associated with this. In transverse, again, we have that ring sign where we have multiple layers or multiple rings. So here's our inner portion of intestine, the intussusceptum, and then the outer portion of intestine, and then here's some fat that is also within the lumen. This patient, the wall layers are a little bit easier to see. And transverse, again, we have that ring sign. Here's our inner intestinal segment with its normal layers, and then there is the outer intestinal segment with its normal layers, and then some fat and maybe even some fluid in that intestinal lumen of the outer portion. In transverse in this patient, we can see there is the intussusceptum here that actually has an associated mural mass that is hypoechoic heterogeneous. And then here is the outer intestinal segment that has kind of a thin wall here, and then there's some fluid and probably some fat that is being trapped in there as well. So this is an older patient in which case the intussusception was caused secondary to this mural mass. Most of the time when we identify intussusceptums, we find them in young patients, and they can be caused by hyperperistaltic type disorders such as infectious etiologies like parvovirus and maybe worm infestation. So that example with the mass brings us into abnormal structure. When we talk about abnormal structure, we're talking about mural lesions, which could have a mucosal component as well. And mural lesions can cause diffuse, multifocal, and or focal changes to the stomach and small and large intestine. When we look at mural lesions, we have differentials that can be inflammatory, granulomatous, or neoplastic in origin. It can be challenging to sometimes identify and prioritize differentials, but the appearance and distribution of the mural lesions can help us when we kind of decide what to include and how to prioritize our differentials. We'll talk a little bit about that. And then we should always consider that although we're talking specifically here about the GI tract, we need to look at our regional structures because alterations, for example, very abnormal lymph nodes, or maybe there's inflamed pancreas or something like that, and then a clinical history, physical exam, and laboratory data can help us with developing and prioritizing our differentials. Let's start with talking about some inflammatory disorders affecting the intestinal tract. Sonographic findings in inflammatory disorders can vary, and sometimes patients with a process such as IBD or maybe even enteritis from hemorrhagic gastroenteritis or dietary indiscretion may have completely normal appearing intestinal walls. However, some patients may have mild or moderate circumferential wall thickening. That thickening can be diffuse or multifocal depending upon the process. I want you to consider that the majority of the time these inflammatory disorders maintain wall layering, so we should still be able to see the wall layers. So for example, when we're talking about inflammatory bowel disease. However, I'll show you examples where the layers may have disproportionate thickening. In addition, the layer echogenicity can also be altered, so our normal hypoechoic mucosa may actually become hyperechoic. We also may be able to identify decreased motility, spasticity, or rigidity. So here are two examples of two different patients who have gastritis. So the patient on the left is kind of a longitudinal image of a portion of the stomach. This is a lumen with gas and reverberation. If we look here, I can see the superficial portion of the wall. It is being measured as greater than 1 centimeter, which is too thick. Remember, we talked about approximately 5 millimeters for this is a dog, for the gastric wall. I can still see layering. I can see mucosa, submucosa, muscularis, and serosa. However, this mucosa is disproportionately thickened and hyperechoic. The other side of the wall looks very similar as well. So layering present, but too thick, and the mucosa is hyperechoic. Here's another patient, a transverse image of the stomach, and this is a patient that has uremic gastritis, so in uremia and secondary gastritis. Again, this patient has wall layering, especially we can see the deeper wall better. We have some superficial near reverberation up here. And when we look at this wall, the mucosa is quite thick. There is also this hyperechoic mucosal line, which can be seen in uremic gastritis. And then the mucosa has a little bit of shadowing associated with it, because I think not only is there some gas, but sometimes they can get some mineralization of the mucosal surface. So thickened, hyperechoic mucosa, still see submucosa, muscularis, and serosa. So wall layering intact. This is an image of a patient that includes multiple transverse images of jejunal segments. This is a dog that has inflammatory bowel disease. And again, in some patients, the intestine can look normal. This patient has a couple segments of jejunum where, especially this one that's being measured, you can see that the wall is too thick. This side of the wall measures up to 5.6 millimeter, and typically we think about 4 millimeter. So down here on the bottom right is a normal jejunal segment image and measurement. Additionally, the mucosas may be a little bit more hyperechoic in this segment compared to the segment adjacent to it, but I still see normal layering. Here's an example of a cat that has inflammatory bowel disease presenting a little bit differently. The patient down here on the bottom right is normal for comparison with a thin wall of 2.1 millimeter compared to this patient that has overall wall thickness of 3 millimeter. Which is kind of our upper limit, so typically a little bit less than that. This patient also has disproportionate thickening of the muscularis and submucosal layers, so they are both very thick, almost as thick as the mucosa, and that is not normal. So normally, remember, they're very thin submucosa, muscularis, as well as the serosa. So this patient has several segments that look like that, but with variation. So very thick muscularis here, not quite as thick muscularis here, and then some of the mucosal layers there have some increased echogenicity. Here's a patient that has a specific type that is lymphangiectasia, and this is a dog. These are all longitudinal images of the same dog jejunal segments, again normal up in the top right here for comparison. And when we see this specific finding, which is this striping here, these hyperechoic lines that are perpendicular to the lumen of the segment of intestine, we call those mucosal hyperechoic striations. That is very suggestive of lymphangiectasia, and this probably represents lacteal dilation. So this patient has that in several segments. This patient also has disproportionate thickening of the muscularis layer in at least one segment, and then has a little bit of spasticity of this segment as well. And then keeping in mind that we like to look regionally, this patient has a little bit of triangular anechoic free peritoneal fluid here, probably a little bit here. And then the mesentery surrounding these intestinal segments is a little bit hyperechoic, so it's probably reacting a bit to this lymphangiectasia. And then that fluid is probably because these patients oftentimes develop protein-losing enteropathy, and they can have peritoneal effusion from the hypoproteinemia. Next, let's talk about granulomatous disorders. These may be fungal, such as histoplasmosis or pitheosis phycomycosis, among the more common fungal disorders. But you can also have sterile granulomatous processes, which could be caused by maybe a chronic foreign body or unknown causes. The ultrasound findings are variable and very nonspecific. Again, most ultrasound findings are nonspecific, and we need to biopsy. The granulomatous disorders can cause focal or multifocal lesions. They tend to be eccentric or circumferential wall thickening. And different from inflammatory disorders, these are transmural with effacement or loss of layering. So that can help us get away from just routine inflammatory like IBD. The wall echogenicity can vary as well, hypoechoic, hyperechoic, or mixed. And then we may see some changes to peristalsis and see rigid looking segments. So here's an example of a duodenal wall in a dog with a duodenal granulomatous disorder. So this wall is thickened here and hypoechoic. There is no layering. This is our lumen with gas. Here's another image of the same duodenum. Wall here is thickened, hypoechoic, no layering. This patient also has kind of an ulcerative lesion in the mucosa. You can see this little crater and some gas tracking from deep ulceration. This granulomatous etiology was unknown. They didn't see fungal and were unsure why it happened. Here's a patient with another non-neoplastic disorder. This is a cat. This is a longitudinal image of the stomach and the pylorus. And if we look at this proximal duodenum here, we can see this focal thickening where we are altering and losing or effacing the wall layers. Here's another portion of that duodenum where again this wall is not normal. It has kind of mixed echogenicity and loss of layering. This is a disease called eosinophilic sclerosing fibroplasia, and this can cause masses like this effacing the wall layering. These patients may also have more of a diffuse abnormality which can look like mucosal and muscularis and actually submucosal thickening. Here is distal to the mass in this patient. The duodenal wall looks a little bit more normal, although the submucosa is thicker than it should be. And then to round out our non-neoplastic etiologies, here is a patient that has a longitudinal and transverse image of the duodenum where the wall looks pretty normal. There's some fluid in the lumen, some gas in the lumen, but arising from the mucosal surface is this very round nodule. You can see here that it is completely communicating with that mucosal surface. The nodule itself looks somewhat similar to the mucosa. And when we identify these may be inflammatory polyps, or they can be adenomatous hyperplasia or adenomatous polyps. The kind of appearance looking like the mucosa suggests that it's benign. They can happen in the stomach, duodenum, or jejunum. So that brings us into neoplastic etiologies. And the sonographic findings of neoplastic masses can be very similar to the granulomatous lesions. We can have focal or multifocal lesions depending on the type of tumor. They can be eccentric or circumferential thickening of the wall. What I do want to say is that round cell cancer, so like lymphoma or mast cell neoplasia, can be more diffuse and multifocal. Most of the time, neoplastic lesions are, just like granulomatous, transmural and efface and cause loss of layering of the walls. Round cell cancer sometimes can maintain wall layering, and I have an example of that. Our echogenicity of the mass can be mixed and similar to our granulomatous lesions. So what this should tell us is that, again, sampling is going to be necessary for a definitive diagnosis. This slide just lists the more common malignancies in dogs and cats and gives you some very general findings that we might see within these lesions. So again, round cell cancer can be focal, multifocal, or diffuse, and sometimes maintains our layering, tends to be circumferential or eccentric. And one thing that you might want to underline is that oftentimes round cell neoplasia is hypoechoic. The other tumor types I have listed here should only cause one lesion, so they are focal. So that would be a way to distinguish round cell from these other cancers, is if you see more than one lesion. Carcinomas can be eccentric or annular, and they're oftentimes complex. Lymphoma rarely causes obstruction, whereas carcinoma more commonly can cause obstruction. Leiomyosarcoma is interesting in that it usually is eccentric, which means it grows outside of the lumen, so it rarely would cause obstruction, and it's usually very complex and oftentimes has a lot of hyperechoic regions. As well as GI stromal tumors can be similar to leiomyosarcomas. So again, not very specific, but just some generalizations. This is an example of a patient with gastric lymphoma, and it is a circumferential lesion. Here is the lumen, this little thin stripe, and if you notice, this wall is diffusely hypoechoic and there is absolutely no normal wall layering, and that is very common with lymphoma. Here's another patient that has multifocal lesions affecting the jejunum. So calling out this little segment of jejunum, this is actually a fairly normal looking wall with some gas and shadowing, but compare that to the other two segments of jejunum where we have this eccentric hypoechoic nodule mass here that effaces layering. Same thing in this segment. When I look at this segment on the right, part of this small intestinal segment actually has normal wall. Here's our lumen, and then part of it has this eccentric hypoechoic transmural infiltrate. So again, a patient with lymphoma. This is a cat that has mast cell neoplasia, and this patient exhibits both diffuse lesions as well as a focal lesion. In the segments here that are depicted to the middle of the slide, we can see that I have ability to identify normal wall layers. Here's our lumen here, but the wall is too thick and there is disproportionate thickening of this muscularis layer. This segment down here is not quite as thick, but again, still has disproportionate wall thickening of the muscularis layer, as does this transverse segment up here. So this is more diffuse. But when we look at this intestinal segment, there is actually an eccentric mural mass that is causing loss of layering. It is fairly hypoechoic. A portion of the wall is still normal. So diffuse and focal lesions are going to lead us to think more of a round cell neoplasia. Lymphoma or mast cell neoplasia could do this. And then, because we look around and assess regional structures, notice that there are lymph nodes in this patient that are markedly enlarged and hypoechoic heterogeneous. Compare these abnormal, irregularly shaped lymph nodes with a normal fusiform, long and thin lymph node in the top right of the slide. Here's a patient that has a gastric carcinoma. Carcinomas can sometimes cause what's called pseudolayering. So here's the lumen with some gas and the lumen with some fluid. And then here is this thickened abnormal wall. And it does look like there might be some layer still present because we have hypoechoic, hyperechoic, hypoechoic. But this is not what the normal layering should look like. So this is pseudolayering. And again, this is a carcinoma. Now, this patient also has a carcinoma. This is in the duodenum. This one is so abnormal, we can't even tell that it's an intestinal segment. Here's the lumen with gas, and then just kind of this hypoechoic heterogeneous mass. This is a cat that has a carcinoma of the distal jejunum. Here's the carcinoma. It's very irregularly shaped. It's heteroechoic. There are regions that are hyperechoic, regions that are hypoechoic. And then, like I said before, carcinomas not uncommonly can cause obstruction. And if we look on the proximal portion of this mass, we can actually see luminal distension. And there are several other segments of jejunum that are markedly distended with heteroechoic fluid here and still have normal wall layering. Here's another patient that has an annular carcinoma that I can see, especially if I look at this transverse image on the right, this hypoechoic transmural infiltrate that has loss of layering surrounding kind of the area of the lumen here. In long axis, the lumen is here, and then we can see this wall that is diffusely hypoechoic and loss of layering. And then finally, here's a malignant neoplasia that is a leiomyosarcoma coming off the cecum. Again, these tend to be very exophytic. So here's our lumen of the cecum. There's a little bit of normal wall here, and then there's this large mass arising that is very hyperechoic heterogeneous. Again, we would have to sample these to know for sure the type of cancer. And then finally, not all tumors we identify are malignant. This is a patient that has a small hypoechoic mass that is arising from the mucosal surface of the stomach and projecting into the lumen. Here's the normal wall superficially here with normal wall layering, and this is a leiomyoma. I don't want to test you on this, but I just wanted to remind you that we can identify intestinal perforation with ultrasound. Sometimes we can actually see the disruption of the wall, which is depicted here where I see no wall, but I see wall adjacent to it. The wall is a little bit hypoechoic and also kind of loss of layering. And here's the lumen with some shadowing. We, besides seeing the wall disruption, may be able to see reactive mesentery, maybe some free fluid, and then sometimes we can actually identify free peritoneal gas. And in this patient, there are these little hyperechoic foci with a little bit of shadowing, which happens to be the free gas, and then there's some fluid around it. Certainly, I wasn't able to talk about everything that you might want to know about regarding the GI ultrasound. So if you want to get further explanation, and certainly if you want to see additional examples, I suggest that you look at the textbook chapters and pages listed here.